It's what this presentation is going to be about. It's a continuation of the previous presentation. So essentially, what I want to do is give a little window into what an actually therapy looks like, at least the beginning of a therapy looks like. Thank you. Unlike Dr. Lewis, or maybe like him, I'm not so sure, I think it's important to put a window into this. I think we can talk in the abstract about what happens, but that's not really what happens. And I'm also very interested in the training of therapists as orgone therapists, because as time goes on, if we don't train therapists as orgone therapists as much as we can train them, there won't be any orgone therapy anymore. And time is moving. So it is very much of an interest to me to bring this work to the psychological and community. And as a psychologist, that's what I'm attempting to do. And I've also found very much that it is, as I mentioned, it is through studying therapy sessions per se that really one gets a sense of what happens. And everything that's been said is true. I mean, every therapy is different. Every person is different. So you can't abstractly apply one technique. But you can study what happens, and you can get a sense of why is this happening? Why did you do this? What is occurring right here? How are you applying your theoretical concepts? How are you conceptualizing things from a moment-to-moment basis? And why is it different? And it's in the process of studying those interactions, studying those tapes, studying therapy per se that we actually learn therapy. And what I'm saying is not unique. I mean, psychotherapy is being taught and researched a huge amount right now. We've moved a far distance from when Reich was originally presenting his training program, training in how to do therapy. Well, we've moved a long distance, and we have a lot more capabilities and a lot more understandings. And I think what people have found is that this is really the way to really bring therapy and the training to the foreground. So because of that, I don't feel that uneasy about talking about a session, or actually even exposing what I did in a session, which is then I look at it and say, "You're kidding me! You actually did that." Because part of really, and that even goes back to what Reich had said. You only talk about your failures. Well, you have failures moment by moment. I mean, every session has a failure, and success. Okay. So really bringing into the foreground what exactly happened and what happened, and I would have done it differently, and here's what I see. And that also brings to the idea of character. Why did I do that? What was it moved by? And it brings to the issue of transference. Did I really understand that? Did it really connect with, was what I seen, was what I felt really in contact? Or somebody else says, wait, I didn't see that. I wasn't, So these are all the things that I think have to be looked at and have to be brought to the foreground as we train therapists. So what I wanted to do is just talk a little bit in kind of a general way, because this is a general audience, and it's also, there's all kind of confidentiality issues and issues about trust and what people say in public. So I'm going to talk about this client, but in ways that if we were actually doing training, if you were in training, we'd kind of go deeper into it. We definitely go deep. So there's going to be some generalities here in terms of the person. And then I just want to go through some of my process notes, because one of the things I do is I take notes after every session, because I wouldn't know what happened in the previous session. I can assure you that. I would lose the sense of the flow. So I take process notes, which is a very common occurrence in terms of psychology and psychotherapy. And I'm going to just look at these process notes, talk a little bit about them, and maybe as I interact with those process notes, talk to you about why I did what I did and what my thinking was about. Hopefully, what I say will tie into what I said earlier today, rather than, well, what does that have to do with anything? I don't know. I wasn't thinking. So a little bit about structure, and if you could give me 5 minutes before the 30 minutes, okay?
5 minutes before 30.
Right, okay, so then I can take questions, okay?
Oh, you want
25
you
minutes.
want 15 for questions?
Yeah,
Got
15
it.
for questions.
Got
Okay.
it.
So I start out a session very confusing. I ask somebody, okay, what I usually do in therapy, this is a pretty common, again, occurrence is, person comes into therapy, I find out why they're there, okay? Asking about symptoms, right? Okay. Person comes in with symptoms, okay? Then I might want to spend some time getting to know the person. I might do that by asking about their life, who they are in their life. That may be one session, that may be 5 sessions, that may be 15 sessions. I also want to get a sense of what kind of relationship we have. And then at some point, if we're going to do biophysical work, and I separate that from orgonomic work because from the moment where we meet, we are doing orgonomic work. If you understand the whole idea that we are working with character structure, we're dealing with emotions, sensations, energy. But if I want to get that other window and begin to work biophysically, then at some point I say, I introduce it in terms of, well, you know, we talked about this, how about we begin to work a little bit on the couch? And then I give a rationale for that, which we've already established this rationale. And I tell them what's going to happen pretty much in the first few sessions. In the first few sessions, I'm going to be we're going to, not only, I've been asking you, here's what I usually say, something to this effect. I've been asking you questions and we've been exploring themes as we sit together. Now we're going to ask your body questions. We're going to ask your organism questions. And we're going to explore your reactions to it, which is the way I conceptualize it. You know, you have a person breathe, you're asking the body a question. You have a person open their eyes wide, you're asking the body a question. You're asking the organism a question. You're asking them a question that you probably couldn't ask them in the other modality. And so we're going to explore this. And in the process of exploring this, we're going to get a sense of how you function here. And what's going to be important for us is to be able to tie in what happens in terms of what we've asked your organism, what we find out with why you're here. Bringing together the understanding of the functional identity between biophysical function, between character, between symptoms. There has to be a correspondence. Somebody comes in, does biophysical work, but it doesn't change things. That's what happened with the client that Dr. Lewis was speaking about. It was clear. Something was missing. We've got to bring it all together. So that's how I begin to introduce that. And then we have a number of sessions. And usually what I'll also say to a person is that, you know, we'll work for a short amount of time, maybe 4 or 5 sessions. We'll see how it works. Maybe this will work. When it doesn't, we'll see what we explore, et cetera, et cetera. Very basic thing in psychotherapy is you set the frame. You know, the frame is the holder, it's the container, it's how we are together, what we're going to be doing together, and you set the frame. If you have a good frame and you start off well in the beginning, things can work out. So one of the things I've discovered in my work is that if I mess up in the beginning and I don't catch it, unlike Dr. Lewis, who was able to catch it, things can go downhill. And sometimes I can't recover from it. Sometimes we can't recover from it. Sometimes there's been too much that went awry, which is very unfortunate. And you know, that's one of the sad things that can happen in when you're trying to help somebody and something doesn't go right. So let me just say that here is, let me see, what time do I stop?
You want?
No.
I'm going to give you 5 minutes and 25 after.
Okay, good. I just want to time myself there. Okay, so here's a woman that comes in. Okay, again, why did she come? She comes because she's been having anxiety and panic attacks. Okay, again, any character structure can walk in with anxiety and panic attacks. She, at the same time, some of this has been associated with she's developed adult onset asthma. Okay, which bless you. Okay. She didn't have asthma, or she didn't really note that she had any respiratory problems for a while, but then she developed this. And this was also developing during a period of stress. And when people say stress, that's a very ubiquitous term. I don't really know exactly what it means, stress, but there was a period of stress, meaning that things were happening in her life for her that she was having difficulty with. And she felt that she was putting herself in a life situation which was challenging, in a work situation that was challenging. She didn't know how to really handle it. So, and then she develops this asthma, and then this asthma becomes kind of stressful because in the sense that, you know, she's having difficulty breathing, and when she has difficulty breathing, then she becomes anxious, and then she's beginning to have these panic attacks, and da-da-da-da-da. So that sets the frame for that, this is what she comes in. And she goes to doctors, and doctors aren't really able to help because they give her these sprays and they give her these medications which don't seem to really change things. And that's why she's had a good number of years of therapy, which seems to have supported her. But whenever a client comes in and says to me, what they got out of therapy was support, I feel a little uneasy about that. Because that's not really what therapy is provide, is support. Therapy provides the ability for the person to support themselves, structural change. So a person comes, they come in, they've done a lot of therapy, it's supportive of them, but something has not allowed for the internal support to be there so that they could actually not feel so stressed within the environment. So we talk a little bit about that. She tells me a little bit about that, about change of jobs, and then a little bit about her upbringing, that she grew up in a religious home, and that she left that for a number of reasons and began to isolate herself. So we begin to, as I'm listening to this, I'm listening to symptoms. The other thing I'm listening for is characterological life events, characterological themes, life structure themes. What has she done in her life? And one of the things I hear very early on is that she's tended to isolate herself. She's tended to feel apart from others. And that this somehow, in the back of my mind, as I'm thinking about it, is I'm going to hold this as a possibility, because when people isolate themselves, they don't have the supports, the real supports in the world to really deal with things. And essentially, I have to look at, is that a theme? Is that a self-representation for herself? That she is separate from somebody, isolated. And what does that mean in terms of her ability to make contact? So here she is, she's very friendly with me, she can talk very easily with me, but is she really in the room with me? So these are kind of things that I'm beginning to think about. So we have another session. In the second session, I get a little more about her history. And just kind of briefly what I'll say about her history is that here's a person who had some major early losses. She lost her father when she was quite young. Then, when her mother remarried, she lost her mother because her mother remarried. And then she was put into a position where she had to raise her siblings. So then suddenly, not only did she lose people who were supposedly supporting her, but then she had to switch roles and suddenly support other people rather than being supported. And then she got into a marriage which was supposed to be really good and supported by her religious community, which tended up to be a total scam or failure. And she felt very let down. So there's a whole series of issues around connection, being let down, disappointment. And one of the things I think I mentioned earlier in the last time is that really one of the things in what we work for in therapy is to help people deal with disappointments. Because the disappointment reaction, the contraction from disappointments, is one of the major things that occurs, or one of the real areas that occurs where we armor, where we control ourselves, where we clamp down. And here's a person that very early on had major disappointments. But people can have disappointments, but that doesn't mean that they have to remain clamped. What makes the difference? The difference very often is, especially for a child, is what does the environment do around that? Can the energy that went be allowed to go, which means can the person process emotionally those hurts? Oftentimes, though, that isn't the case. So what happens is that these things have to maintain themselves. And that becomes maybe the underlying characterological, biophysical kind of situation. And it seemed possibly for this person as well. Okay, so here's what I know. 2 sessions, and she's had therapy, and we talk about that. Then I suggested to her, because she was interested, because of her somatic problems, she was interested in coming into therapy to deal with something somatically. So the next session, I had her lay down, and we did what is in parlance maybe called, and I think Dr. Lewis alluded to it, a biophysical exam. Or, I'm not trained as a physician, so I don't know if I do exams per se, or biophysical analysis or whatever. Essentially the way I think about it, and the way I talked about asking questions, is that really we're continually, this is an ongoing process. And what I've also found is sometimes in the first session when a person lays down, you get a totally misrepresentation about actually what the person can do. Because the person is there, they're under these kind of conditions, suddenly a lot happens, and then nothing happens or other, or nothing happens and a lot happens. You know, we don't really know how this person is going to structure themselves. So over the first few sessions, we're getting more of a sense of what is happening. So I ask her to lay down. And this is not seeing that most of you have done therapy. This is not, oh, you have the person lay down. What do they do when they lay down? So my work with people is I don't have them unclothed. I just ask them to wear clothing that I can see their respiration and that they can move freely. And that wasn't the way I was originally trained or my therapy. That wasn't it. But I find that, I don't know, I find maybe I'm more comfortable with it, clients are more comfortable with it. I find that given that I'm not as visual a person as some other people, you know, I can pick up enough in those kind of situations. And there is something about when a person lays down, you've already changed the dynamic. You've changed your balance with the person. You've moved into an adult-child relationship. And then when a person is further unclothed, you've even changed it even more. So I tend not to do that. And the person lays down. I ask her to lay down. And then it'll be very typical. So what I say to her is, okay, could you just lay down there and what do you feel right now? So I asked her what she felt. And that's kind of a basic kind of question, because when a person is armored, they feel less, right? Okay? So you ask the person what they feel. And then I asked her to breathe. Okay. So what I'm doing is I want to find out in the initial sessions what happens if I ask her body, if I increase your energy, what are you going to do with it? What's going to happen emotionally? What's going to happen? What are you going to do with your excitation? But not only that, in the process, you're going to connect what's happening here with your life. So I asked her to breathe. And so I noticed that. So what do you notice when a person breathes? If most of you have been, you've worked with yourself, but if you've actually watched people breathe, you kind of start to get a little bit of a sense of what moves and what doesn't move, what seems to be mobile and what doesn't seem to be mobile. Sometimes people breathe more in their bellies, less in their chest, sometimes in their chest, less in their bellies, sometimes the diaphragm moves, sometimes the diaphragm doesn't move, sometimes they seem to move freely, but then if they feel any emotion, things kind of stop. And those are the kind of things you're looking for, or I'm looking for. So one of the things I noticed is that she breathed pretty freely in her belly, but her chest was kind of immobile, not really moving very much. Okay. Now I could then ask her to move her chest more, which would be an interesting kind of thing in terms of again, in terms of asking her these questions. So as she began to breathe, though, she said, this is what she said. She said, I'm beginning to feel a little fear. Okay. So she says, so I said to her, how do you know that? And because I don't know, sometimes I think that's an appropriate question. Or say, well, I'm feeling sad. How do you know you feel sad? Or where do you feel sad? Or what's going on with that sadness? So I said, how did she know that? And she couldn't really tell me how she knew it. In fact, I said, well, where do you experience the fear? Do you feel afraid in your eyes? Or do you feel something in your chest? And she couldn't really tell me that. So that became a little bit of an indication to me, or something that I'm holding there, in terms of her armor. In terms of maybe how she walks through life telling herself about how she feels, but is not really sure how she feels, or can't really localize how she feels, and that there's a kind of a disconnection here between herself and her biophysical reactions. So I said to her, well, could you, if you're feeling a little afraid, can you show me that fear in your eyes? So going back to step one, or whatever it is, even though it's maybe not step one, ocular segment. 2, asking, because these are the questions I ask. I'm asking her organism. What happens if we mobilize a certain segment in a certain way? What emerges? So I said to her, well, couldn't you show me fear in your eyes? Again, if you work with people, you see multitude of possibilities. Some people can show fear in their eyes. Some people can look terrified and not feel a damn thing. Some people can not feel anything in their eyes. Some people can say to you, I have no idea what in hell you are talking about. So all these kind of responses that you can get, and each one is meaningful and meaningful by themselves and in the context of. So I asked her if she could show fear in her eyes. And again, it was very difficult for her. It was very difficult. She didn't really get it. She didn't really know exactly what I was saying. What can you show fear? So I said, well, can you do something with your eyes, with your ocular expression, with your eye expression to become afraid? And she had difficulty doing that. Okay. So then I moved to something, again, another question. I said, well, can you open your eyes wide and close them tight? So what am I doing there? Just, well, one, because if you know, or one of the things, when a person is afraid, you know, especially when a person is frozen in fear or kind of fear, their eyebrows kind of go up like that. And there's a whole respiratory kind of response. And okay, and if you're going to show fear, and in fact, if you do that for a while, I don't think you need to do it right now, but if you want to experiment with doing that, you know, you might suddenly feel a fear reaction like that as you come. So the mobility in terms of the face is very crucial. It's very crucial in terms of both expressing emotion and feeling emotion. So I just said, so can you open and close your eyes? And sometimes in orgone therapy we do it a little mechanically, open and close your eyes, close and open your eyes, and just to free things up. But the whole idea is to get life into the organism. So I asked her to do that. And she found again. She found that she could do it, but as soon as she started doing it, what happened? She stopped breathing. So again, so when I think about that, this is my set. May not be true because I'm thinking ergonomically, but my set is that this. Here is a person, she can do this, but she can't coordinate with her breathing. One, because she's not really used to being in her body. And two, because if you start doing this and coordinate it with, and you have your breathing moving too, there's an increase of excitation. So as one thing opens up, the other thing shuts off. Okay, so I have her do that. How we do it?
You 5 before you're 50.
Okay, thank you. So I have her do that, and then she says to me, you know, I'm not used to being in my body like this. This is very strange. I'm not really used to being in my body. And I'm not used to showing any kind of emotions. Okay. So here we begin to have this first link. Yeah. This is not something I'm saying to her. I want you to notice that you're not used to being in your body, and that you're not used to showing emotions. But she comes to this through this experience. Okay. And that becomes a very major theme in our work. How she's not used to being in her body, how she's not used to showing emotion. So I said to her, okay, why don't you try this as an experiment? Now what I'd like to do, I'd like you to make a sound as you exhale. Kind of again, kind of going through segments. So I asked her to sigh. So you just kind of sigh. So she does that a little bit, and she says, wait, I don't feel comfortable doing this. Now, it's good, it's good. There's some compulsive individuals, if she was a real strong compulsive, she'd do it anyway. You know, she wouldn't really even notice that she would do it. You're telling me I can do it 20 times, and I can do it 30 times. Yeah, but obviously, if you want to talk about character structure, obviously she doesn't fit within a pure compulsive kind of thing. She begins to do it, but she's reticent. I'm not used to doing this. I'm not used to making sound. And then she says to me, you know, in my family, you know, the message was that you don't make sounds. In fact, you don't pay attention to yourself. You only pay attention to others. You pay attention to others' sounds, but you don't pay attention to your sounds. In fact, she says, this message came from her mothers, her mother and her grandmother, both of whom had early losses of significance in their families. And it's amazing sometimes the way these things can be transgender. Okay. So, here we have a connection, in my mind, of a biophysical reaction and a characterological reaction, and what that here comes together. Okay? I don't attend to my feelings, my biophysical feelings. I don't make a sound. And I don't make a sound because I'm not supposed to make a sound. And I'm not supposed to attend to myself. And if I do, I'm transgressing something in myself. So I cut myself off from it. So my orientation in the world is to the other. So I become a healer which of course we therapists know how that can be, you know, possibly being trained early on in the realm of looking to others but not to ourselves. I become a healer. I listen, I pay attention to her as she was in kind of a healing kind of profession, and I'm very good at it. But that's where I attend, not to myself. And that cuts me off from myself. So we stop there. So we talked about that. So one of the things I want to say in terms of this process, and then we'll stop in a little bit, and I'm obviously just giving just one kind of session, is that there's, in this way of exploration, which is just the beginning sessions, but it shows certain kind of theme, there's a beginning of doing something and processing something. Doing something and processing, at least with this person. Because she had these strong reactions. They weren't strong in the sense of, oh, she's starting to cry very deeply, or she's doing all these shaking and things which can happen in sessions which are quite dramatic. But strong reactions in terms of she had responses to these biophysical interventions. And then she began to make connections between these biophysical interventions and aspects of her character. And then we continue. So what happened then is further on in this particular session, you know, as she does something else, she began to cry a little bit. Okay, so we have, notice this, first I can't show fear, then I can't make a sound, we kind of process that, we talk about that, and then as she makes a sound, she begins to cry a little bit, and then she contracts again. And she says, wait, it's not permissible to cry for myself. I can only cry for other people. Now, what fascinates me, I don't know if it fascinates you, but I might as well be fascinated, is that how many characterological themes can represent themselves in a short amount of time. And it wasn't like I was working very hard or had to do a lot of digging or whatever. With this person, and it's not always with other people, but how many characterological themes begin to emerge as you begin to ask somatically what is happening, as you begin to move the energy, as you begin to evoke emotion, and then you see how the person organizes themselves around that. And I can say, like with her in the course of therapy, other things began to emerge and stuff like that. But a key element is that she isolated herself. She kept away from people, she couldn't trust people, and she couldn't move toward people, and she could only attend to people within a certain realm of helper, and literally her organism was dying in that relationship. As that began to change, which is as she can feel, as she can turn to me, as she can cry, and of course the big thing for her is as she could become angry, which of course if she couldn't attend to herself and speak to her own needs and cry, how could she become angry? Things could change in her life. So that's my little thing, my little window. Okay. It's only a small window, because if we go and we look at the next session, we'll see both how those themes continue and what new information we get, and how they change, and how things move. But we're also going to see, if we continue, the red thread that goes through the whole therapy with her, which becomes increased. And hopefully we will see in the course of therapy that, in actuality, she will be able to eventually show fear in her eyes. She will be able to cry with sound. She will be able to get angry and express her needs. And in doing that, her whole organism become more and more involved. So part of what I see in terms of working down the segments, and maybe I've said this in another talk or whatever, is that essentially there are some basic emotions that we work with, but how deeply felt and expressed are those emotions? And as you work down the segments, these emotions, like for her, a little cry is a big cry, but a little cry is just a little cry. And as she goes deeper, that little cry becomes a bigger cry, but that big cry is still a little cry. And as she goes deeper and deeper and deeper, maybe as we progress there will be the crying for her father, there'll be the crying of her mother for her mother's father, and the crying that her mother never did, and the crying of her grandmother for her mother, for her father, for her. And there will be this crying that sits right down there that prevents this from moving. And as this moves, and as she can do that over time and cry for herself, then she that will be part of her breathing again. And then she won't have to anymore, which wasn't working that much anyway. Okay. So that's a little window, but please ask some questions. So let me ask you a question. Was it helpful to talk about like this, I mean, in any way?
Yeah.
Yes.
Yeah? Okay. Okay. And it's a portrayal. Okay? The other thing I want to say, and then I'll get to you because I stunned. It's like, I'm a little distant from this. I'm kind of talking about it, but it's a little distant too. I can't really tell you what happened moment by moment. But if we looked at this, we would find those places of meeting, and and we might even find what was really important and what wasn't important. And there was a wonderful book that, I don't know if you've ever read, probably not, Irving Yalom wrote. He was an existential therapist. He wrote this book with a patient, and I can't remember the name of it, but every day gets a little bit closer, I think it was. And he wrote his notes, and he had the client write their notes about therapy. And what was amazing to him was that the things he thought was important was not important at all. And the moments of significance for the client was something that he even would forget. You know? And so, you know, that talks back to transference and contact. Sometimes we don't really know. And I remember one client once telling me a long, long time ago, she said, you know, therapy was really helpful. One of those times. She said, what was the most significant, what was so important to me was one time I was laying down and crying, and you went and gave me a blanket. You know, and I would not have known that. I would not have known that. That thing that I did, not out of some great theoretical, you know, armor and dividing of forces, and whatever, not out of something like that, but something that I just did because it looked to me like she needed a blanket. That was, sorry.
I think windows are useful because, or maybe some of the trepidation around windows is if somebody doesn't make a distinction between the general and the specific.
Mm-hmm.
You know, if you get tied to the specifics, that's when it becomes mechanical. Okay, do step 1, 2, 3. But if the specifics are used to illustrate these general principles, then it is useful. And you just gave, you know, a very clear and detailed illustration of contact. You know, rights defining contact as a merging of excitation and perception. That's the general thing. And all those different details you gave between the breathing of the throat and the chest or everything. In her case, you were observing excitations and you were bringing them to her perception, so contact could happen, and then the integration happens spontaneously.
Right.
But you just have to keep bringing the person into contact at the level that they can tolerate, at the speed they can tolerate, which also requires contact. You know, so you're giving an illustration of that general and functional and essential tool, but with specifics that nobody has to use for anything other than just to get and understand contact.
That's right. Exactly. Very well put. Exactly. Yeah.
This is a mechanical question, I realize, but do you have like a set thing that you do when you get lost in a session in the middle of it or something? Like, let's say arbitrarily go back to the eye and try something different with the eyes, being that that's mechanically the beginning of
Well, when you say when I get lost, what do you mean?
Like you don't know what's going on and you can't, you know.
Well, if I'm aware enough to know that I don't know what's going on, okay, which is an important step. I'm not even being, I'm humorous about it, but that is really important. Okay. I think that what I will do is I will often say, well, what's going on? I will make some, you know, I will consider, you know, what's happening right now for you, or what are you feeling right now, or what's happening between us? How is this going right now? And I will check in, because one, if I don't know what's going on, maybe my client knows what's going on. At least they know better than I do what's going on in them. Then maybe they know what's going on between us. And that's what I'll do. I won't, so in the sense that addresses your mechanical theme, because to kind of go back is like, okay, well, this isn't working, so I'll just do that, as if I'm making a decision myself, working on some mechanical structure, rather than what's happening. What's happening between us? And I think that's really important, and I think that, you know, whether or not you're working with a person on the couch or not, a kind of continual kind of dialogue about the process, about what is occurring here. And it allows people to meet. Does that answer your question?
Yes, yes.
Could you say a little about how the grandmother's trauma or tears or suffering got lodged into the patient, or could get lodged into a patient? Because you're mentioning something.
Yeah, you know, I mean, can I say how it does? I mean, there's some I know, what I know most is that I know very little. So how it exactly does, I'm not exactly sure. On the other hand, I think as children, we pick up unprocessed feelings. And they get conveyed in many ways. And these things are generational. And we pick them up. And so many times, clients have said to me, as they're crying deeply, or as they're feeling something deeply, this is not only my fear. This is not only my sadness. This is not only my rage. This is not only my shame. You know? And and it isn't, because it's because we take in, and then that shows itself in a character, and then it's how we interrelate then with our children or the other, and then they pick it up. And it's there. And there's some knowledge about that. So that's the best I can do. I can only do between kind of what my clients tell me about that. But I've seen it enough. I've seen it enough and felt enough to kind of know that it's there. And there's always a feeling then, we're going to stop it now. So you know, there's a way of breaking the chain. You know, breaking it. We're going to stop this now.
Yeah, I mean, what might be helpful there is, since we're talking to some extent about modeling, processes of modeling, the way children model. And so what Wright did not have available to him was the work yet of Ainsworth and Bowlby, and particularly Daniel Stern, child psychiatrist, who I had the pleasure of working with for a little while. And when you see these processes about how it becomes yours, it has to do with what Stern called, and I'm not going to go into elaboration, I'll just quickly say, attunements. And that what mothers and infants do, and then later on adults and children do, is they go, and what we all do, what we do in this room now, continuously, is the way we maintain our relationships with each other is through very specific processes of attunement. Right? And they're very subtle. As a matter of fact, when you actually look at where attunements take place, they usually take place roughly within a fraction of a second. And that because of microanalysis now, we can actually digitally get down to and say, there was an attunement. You know, it's not supposed to be something you even see or know. You know? And so one of the reasons I think Dr. Schiff is right in saying you can't exactly say when or how it happens or how it becomes yours. It becomes ours, and it gets transmitted through these continual repetitive processes of continuous processes of attunement, which are natural to our organisms. It's the way our organisms maintained ourselves in relationship to each other. And I think Reich was on to that, but I don't think he had enough data yet or understanding to understand exactly what he might not even been as interested ultimately in seeing that, but I think it's useful in terms of understanding how it gets transmitted and why very often our patients don't understand, or why we can't understand how that became part of us.
Yes, thank you. Yeah.
I was just going to mention there's also a couple of books that have come out recently by some colleagues of mine on this idea of transgenerational trauma, where especially things like the Holocaust will somehow be transmitted from generation to generation without it ever being spoken about. And this is something that seems to be being discovered in various segments.
Yes.
Yeah, I've seen this in my patients more and more in a general sense, not even with some extreme trauma like that, but almost this could apply in a general sense. And seeing how the actual biophysical as humans are part of that helps even more understand how, like the chin. And you were speaking of earlier, the mistake that because something even is physical like that, that it's genetic rather than picked up in this attunement.
Yeah. Interesting. You'll have to give me those references.
I once took a fairly good amount of hallucinogenic mushrooms and connected with this certainty that I had killed somebody when I was a kid and nobody told me. And it actually, and it was kind of terrifying at the time. But I knew enough about my own brain to go, well, wasn't that interesting? I'm terrified. But later on, much later, through therapy and quite honestly, some future entheogenic sessions, discovered that it was actually my father's father who probably killed his wife at the time, which would have been my father actually remarried, and that mother was the mother to the father. But anyways, it took a lot of kind of unearthing to get to that same place. And it wasn't something that happened to me, but it was something,
Right.
and I don't even know if my father knew about it.
Yeah.
But much later, the stories came out from some other angle in the family. And that shame and that kind of, we could call it the stain, you know, got passed along to really all of my siblings in a variety of different ways. But, you know, kind of bypassed my father's generation, but his father had most likely killed his first wife.
Yeah.
And that secret
Yeah.
got imprinted.
Yeah. Thank you. But, yeah.
A crypt.
Yeah.
That's the way it's spoken,
Yeah.
like it's a crypt, it's encrypted.
Yeah. Thank you.
Keeping with this idea of like new knowledge and new ways of, or more knowledge to be able to understand what's going on, and at the risk of maybe being mechanical, it seems to me that the patient is more than just the patient in this sort of generic sense, and so our social cultural knowledge that we have about gender and
Yeah.
class and ethnicity and race, and there's so much out there that gives some general patterns about, I mean, it's no surprise to me that 3 generations of women would be other-oriented. I mean, you don't need a trauma for that. It's sort of
Yeah.
how, so it would seem, how do we infuse this work with more sociocultural theory and empirical research without reducing it to stereotype or mechanical response? Just because I'm a woman, I will cry more easily. You know, that kind of
Right.
reduction. On the other hand, every time I come to these sessions, I feel like we forget that the organism in front of us is shaped in a very real way by these social cultural types. And I think it would just really help our discourse, for me, to be able to name that more and not just have it be the generic patient, because I think it really does matter. It doesn't say everything, but it's a real important piece of knowledge that is going on between the therapist and the patient.
And everyone is, including the therapist.
Right.
Yeah. Well, so, you know, in the context of this, in this client talking about how her family as a small socio-cultural climate, you know, shaped her in terms of her being a caregiver. Yeah, and yet, yes, you can say that it doesn't surprise you that, you know, women in general would, but not all women do.
Right.
Okay, so there's some sort of a familial, and then in her context, a religious kind of context. Okay. So, but then kind of going back to one thing, I think as if we kind of go to Reich's idea that underneath all this sociocultural stuff, we are biological organisms. Okay, and that becomes a tricky point that one might want to either be trip over or contend. We are these biological organisms, and as biological organisms, there are some commonalities. And so, to me, crying is crying in pain and pain, and anger and fear is anger and fear. Some of it is frozen, and some of it is done in one way or another. And I really, but then this is my lens. So I'm really with you on that. I don't see a difference. You know, I see when the sound of pain is the sound of pain.
But let's just go back to what Dr. Lewis was saying earlier about if somebody's very comfortable with crying, let's say, he might say, stop crying, move to something else.
Right.
So that crying may not really be the same as someone else who finds it extreme. Like you were saying, this person, a small voice, a small cry.
Yes.
I don't know. It just.
Well, but I think one point is that every emotion can be used as a defense against anything else. Anything can be used as a defense. In fact, this whole discussion can be used as a defense. Right? Yeah. Anything can be used as a defense, and that's the point in terms of the crying. A person can cry, but there's actually something else there, and the crying stops that. So, the fascinating thing is that, can this person really cry? Because later on when they cry again, after the anger or the fear comes out, is the crying the same? And not only is it the same externally, but do they experience it differently? Okay, so that's...
It seems to me on that topic, to me it's the same, it's akin to the question before of whether the birth trauma memory of it matters. Because, what's present in the relationship between the patient and the therapist, and what's blocked and what's not blocked and whatever, that's what's important. And no matter how aware the doctor might be about some sociological context that might have affected this person, and then there's something else that the doctor will not be aware about. You can't be aware of everything.
No,
So it's all helpful, whatever you know might
it's
be
how you
helpful.
see, how you
But
see.
I think the point here is that direct contact with the present, with what's happening in the present, sort of, becomes primary. And that's what I'm saying.
Okay, I think we have to stop, but we will have a discussion later on, right, afterwards, and we can kind of come back with all.
We will reconvene in 10 minutes.
Hold that question.
Sure.